Hi, this is Elliot Fishman, and this talk will be on a very interesting topic, something that probably most of you aren't doing, but something we hardly ever did, but now we do a lot of, and that kind of sounds complicated, but it's CT cystography. And this is actually based on an exhibit we had at RSNA 2007, and hopefully you'll see this in press in the near future. So traditionally, cystography was done for many different conditions. It was done in the trauma situation. It was done looking for fistulae. It was done for post-surgical change, post-surgical leak. But we've noticed, of course, and many have, that CT is an ideal study. Now, in saying this, most of the work looking at the bladder with CT, in terms of cystography, was in the trauma scenario, where you knew that CT was indeed very good and had replaced conventional studies, and of course can be done very conveniently in the trauma center. One of the things we learned, of course, in that scenario is if you're going to do CT of the bladder, it was not enough to give IV contrast and wait for the bladder to distend. You would miss a lot of injuries. To really get a good look at the bladder, you need to have a dedicated study where you put contrast in the bladder. You can use air for select applications, but typically contrast is the way you want to go. Now, you also can do CT cystography for looking at tumors, and we'll do that a different time. We'll talk about tumors, but let's talk about non-neoplastic conditions. Let's talk about trauma, fistulous tracts, which may be post-op or due to diverticulitis, for example. And it's not just using axial images, but the combination of MPR and 3D imaging is going to be very, very helpful. And so in this presentation, we're going to look at some of the techniques of CT cystography. We're going to look at various applications and discuss basically how we do it on a daily basis. So typically we'll do it on a 64-slice scanner, and we'll go with the thin collimators, 0.6 collimators, 0.75 millimeter slice thickness, reconstructed at 0.5. So we're having isotropic data sets. Scan parameters, you're through the pelvis, so you need to have a little bit higher dose to get good quality, but typically 120 kV and 150 to 200 MAS, depending on the patient. Now what you want to do, as I mentioned a moment ago, is distend the bladder. So we put a small Foley catheter in the bladder, and then we drip contrast under gravity into the bladder. Now, how do you do it? Very simple. Perfect solution is take a 500 cc bag of normal saline, add 30 cc's of Omnipaque 350, shake it a couple times, mix it up nicely, and then hook it up and let it drain in through gravity. That works very nicely, regardless of the application. What we'll typically do is we'll then initially scan the patient without any contrast in the bladder, scan them at maximum distension, and then drain the bladder and rescan the patient. Some things show best, sometimes small perforations on the delayed scans, but most of the time it's that image with the bladder well distended that shows you the fistula and shows you very nicely any perforation or extravasation. In terms of minimum and maximum, I guess I'd be concerned about theoretically perforating the bladder, but with gravity it makes life simple, and typically you'll get in 300 or 400 cc's, and that indeed works very nicely. So it's something a very easy protocol to use. Now, since we do have thin sections, we'll send it to the workstation. We'll use a combination of multiplanar reconstruction, particularly the sagittal reconstruction works well, and then volume rendering. I will, of course, look at the axial imaging, but the combination of these two techniques indeed is a very simple way of doing things. Now, if you consider bladder rupture, the most common causes of bladder rupture are trauma, and typically it's associated with blunt or penetrating trauma, but most of the time it's basically related to non-penetrating trauma, in our experience, an auto accident, when the patient typically has multiple pelvic fractures. It's rare to see a bladder injury in the absence of pelvic trauma with fractures. When you see fractures, you indeed have to worry. Now, it's possible to have other causes of bladder rupture, somebody who's getting a cystoscopy, from radiation, theoretically from a diverticulum that perforated, or just maximum distension of a bladder, a patient who had a little too much to drink, and then has very minor trauma. You can theoretically have bladder rupture, but most of the time we talk about trauma. Now, you talk about bladder rupture, you talk about two types, intraperitoneal and extraperitoneal, with extraperitoneal being about 65% of cases. With intraperitoneal bladder rupture, what happens is these are the patients where surgical repair is required. Extraperitoneal ruptures are typically treated with catheter drainage and you do not need to operate. So this extraperitoneal versus intraperitoneal is indeed very important. Remember, intraperitoneal, you're going to outline the bowel loops, so you know it's intraperitoneal, but it does have a major impact. Occasionally, you will have combinations of intra and extraperitoneal, and those are treated as if they're intraperitoneal with surgery. Now, CT is very accurate for diagnosing bladder rupture in patients with acute trauma. There have been a number of articles. Quiglin had an article which basically showed that the sensitivity and specificity was 95 and 100% respectively, versus basically the same numbers for conventional cystography. Remember, we speak about lower dose with CT, but also the fact the patient is on the table already getting that rest of the CT scan, so you're really decreasing the dose because you're looking at the pelvic fractures, you're looking for potential vascular injury, at the same time you're looking for bladder injury. So that indeed can work very nicely. Now, with intraperitoneal rupture, what you see is extravasation of contrast into the peritoneal cavity, and you see it going around bowel loops, you see it in mesenteric folds, you see it in the paracolic gutters. It kind of travels the way you think about ascites. It travels all around, can travel between liver and diaphragm. All depends how much urine there is or how much contrast there is. Now, with extraperitoneal rupture, it's typically seen as a collection of contrast confined to the extraperitoneal perivesical space. It tracks down with pretty well defined, it's not moving across bowel loops, for example. So it's very important to make that distinction, but those are the two major factors. Now, besides trauma, we talk about fistulas, and the thing we typically would speak about in the past most commonly were colovesical fistulas. Those are the most common fistulas, colovaginal fistulas. We've written about both of them. Remember, prior to CT, colovaginal fistulas